Senator Young.
Dr. Price, so good to see you here today.
Thank you.
I've enjoyed our service together over the last 6 years in the House of Representatives, particularly the 4 years we spent on the Ways and Means Committee. And I had an opportunity not just to get to know you personally there, but to observe your quite impressive skill set, your depth of knowledge in the area of healthcare and health policy, your commitment, more importantly, to seeking alternative perspectives, to trying to identify where bipartisan consensus could be realized, and ultimately forging consensus around some viable solutions. The one that I find most notable is your success on the sustainable growth rate, which is something the members of this committee are familiar with, but it's a blunt instrument that was in place to control healthcare costs. And without your leadership over on the House side, I don't think we could have moved towards a more value-based purchasing model. So these are skill sets that will serve you well over at Health and Human Services, no doubt. One area of the Affordable Care Act, speaking of bipartisanship, that members of my party, of your party, have periodically and quite vocally indicated their desire to repeal from time to time has been the Center for Medicare and Medicaid Innovation. And that's perhaps on account of the one-size-fits-all prescriptive and mandatory demonstrations that occurred in recent years. And you've already indicated that you oppose the mandatory nature of demonstration projects. But I strongly believe, for one, that there's great value in innovating and experimenting across all layers of healthcare. Further, I think CMMI is and can continue to be a helpful laboratory for healthcare experimentation with respect to delivery models, payment models, and so forth. For Medicare, for Medicaid, for the Children's Health Insurance Program, perhaps other areas. Save taxpayer money, provide greater value. We see what doesn't work. We scale up what does work. For me, it's common sense. This is the way sort of scientists operate, is they start with experiments, and then they evaluate, and then they scale up. So I'd like to know your intentions, if you have strong convictions in this area. Do you intend to keep this innovation center, or perhaps develop a new one, a variant of CMMI? Speak to this, please.
Well, I appreciate that, and I'm, as I mentioned, a strong advocate and supporter of innovation at every single level. It's only through innovation that we expand the possibilities for especially in the area of healthcare, for increasing the quality of care. So I'm a strong proponent of innovation. The CMMI entity, I believe, has great possibility and great promise to be able to do things that will allow us to find ways in which we can change the payment model, ways in which we're treating disease and the like, that will improve to the patient's benefit. And I strongly support that. I have adamantly opposed the mandatory nature with which CMMI has approached some specific problems. And let me mention two in particular, if I may. The first is the Comprehensive Joint Replacement, the CJR program, which identified from CMMI 67 or 68 geographic areas where if you were a patient and you received a lower extremity joint replacement for a variety of problems, then it was dictated to your doctor what kind of prosthesis, what kind of surgical procedure your doctor could do for you, regardless of what's in your best interest. Now, they may be aligned, but they may not be aligned. And if they're not aligned, then your physician is incumbent upon doing what the government says to do. The other area that I think was even more egregious was covering 75% of the nation in the Medicare Part B drug demonstration model. In fact, not a demonstration model if it's 75% of the country. And that would stipulate what kind of medications your physician could use in an inpatient setting. In a mandatory way. Now, the problem that I've got with that is that really is an experiment. It's a demonstration to see whether or not it works. And in every single experiment, healthcare experiment or medical experiment or scientific experiment that deals with people, real people, we require that there be informed consent for the patient to participate in that experiment. And so you say to the patient, we're trying this to see if it works better. We'd love to have you join us. We think it may inure to your benefit and the benefit of more individuals across this land. But if you don't want to do that, you don't have to. The federal government doesn't do that. They require individuals to participate, and oftentimes, I suspect most often, the patient doesn't even know that it's an experiment that's going on. So if either of these models were put in a small area, a pilot project somewhere, and we saw that in fact they worked, then as you say, then you scale them up.
I thank you for the fulsome response and the rationale behind how you've arrived at that position. I look forward to working with you to advance the next model of CMMI, whatever exactly it might look like. I'd be remiss in my remaining 90 seconds if I didn't mention Indiana's what we call Healthy Indiana Plan 2.0. Our Vice President-elect, Pence, showed a lot of leadership here, worked with our incoming CMS Administrator, Seema Verma, to develop a model for Medicaid, which is unique to the state of Indiana. It encourages recipients of Medicare dollars to get some ownership over their health. It uses private market insurance concepts to prepare Hoosiers for more self-sufficiency. I happen to believe that it will be replicated in other states if we can accommodate that as we continue to work on new healthcare legislation. But HIP 2.0 is an important proof of concept that Medicaid can be more efficient than a one-size-fits-all approach. And I just need some assurance from you that your lodestar will be state flexibility and innovation in the Medicaid space, so we can continue to accommodate plans like HIP 2.0 as opposed to a one-size-fits-all approach.
I think you're absolutely right. The Medicaid program is one where the states know best how to care for in the best way their Medicaid population, and the greatest amount of flexibility that we can give, I think, for states to enact those kinds of programs. What Indiana has done is really a best practice, I think, for many other states to follow, and so I look forward to working with you.
Likewise.
Thank you, Senator Young. Senator Murphy.